Sunashri Garu, you can start the webinar.
Yeah, thank you, Savan. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare.
Okay.
I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. A.B. Fuzayel Ahmed, sir, who is very known and no need of any introduction. He completed his medicine and MD in obs and gynecology and dialogue from RCOG, FIOG, and he's a histro and laparoscopist, and he's a consultant at the Department of Obs and Gynecology, Silchar Medical College. And with this, we welcome you for today's webinar, sir. And
Thank you.
Today's webinar is streamed through Shield Connect, which is a digital platform of Shield. And I request all the delegates, please do visit Shield Connect. And if you miss any part of this program, it will be available in the Shield Connect. And coming to the today's topic, as we know, infertility is a major concern nowadays. And not only female, there is a male factor in infertility, and which can leads to 30 to 40% of infertility. And now, without wasting much time, let me turn over the time to Dr. Ahmed, sir, to talk on male infertility. Over to you, sir.
Hello, good evening, everybody. Thank you so much for giving me this opportunity to speak few words about this infertility. And this Shield fraternity, particularly, they have asked me, hello, am I audible, sir?
Yes, sir, you're very much audible.
Okay. So this Shield fraternity, they have given me this option. I'm really very much thankful to them. And they have asked me to speak something about this male infertility. Now, you know, what is infertility, that is all very well known to everybody. Now, this infertility can be broadly we divide in male factor as well as the female factor. Now, particularly today, I will be stressing upon the male factor infertility. No, actually, this male infertility, earlier actually during my graduation, when we were taught about the graduation as well as post-graduation, when we were taught about this infertility, most of the times you used to blame the female partner as the cause of infertility. But nowadays, actually, the scenario is changing. The scenario is changing from the one post to the other side. Now, what we have seen after a lot of studies and even going through a lot of publication, now it is seen and it is really universally accepted by all researchers that the male factor infertility is also playing an equally important role, equally responsible role in causing infertility in a couple. Now, this male factor is responsible almost around 50 to 40 to 50% of the cases. And what is important is that actually day by day, this male factor infertility in a couple is going on increasing, and that too in an alarming rate. Now, coming to this infertility, now actually almost many things in relation to the male partner in an infertile couple is unknown. But now things it is seen that I'll tell you the causes, but it is seen this in almost, if we categorize the different chapters of a male infertility, then almost around 30% cases, it is the cause of male infertility remains idiopathic. We do not know the causes. But what happens surrounding, if we find out the causes and finally go to the pathology and pathogenesis, you see this in almost in all causes, the oxygen radicals, these free radicals are responsible in causing damage in the sperm, maybe in the head, maybe in the capacitation, maybe in the chemotaxis, maybe in the acrosomal reaction, maybe in the meat piece, or maybe in the, if you go molecular level, maybe in the mitochondrial level. Now, there are many factors in a male body that induces this cause of infertility. Now, coming to certain systemic pathologies. Now, for example, if the male partner is having diabetes mellitus, one, if male partner is having some sorts of cancer, if the male partner is having some sorts of systemic infection. So I'll go through details in that. So these are the systemic things, okay, what indirectly or directly that affects the male factor. Now coming to some of the lifestyle factors, for example, drugs, some sorts of drugs the male is taking for long duration, he is consuming, some sort of bad behavior like smoking, chewing tobaccos, all these things comes into play. And even, of course, our environment, the pollution and radiation, that goes without saying. But all these factors finally leads to generation of an abnormal and excess and uncalculative amount of radicals. And that radicals causes damage to the spermatozoa in different ways. Maybe in the form of motility, maybe in the form of structure, maybe in the form of other things like episomal reaction, and whatnot. So all this together, they cause some sorts of spermatozoal dysfunction, and that leads to the infertility. Now coming to the little bit about the physiology, how does spermatogenesis take place? There's the axis. It is almost known to everybody, every gynecologist who are practicing infertility. I mean, the axis is hypothalamus pituitary ovarian axis. Now, what happens? This hypothalamus that releases the releasing hormone, because here is the gonadotropin releasing hormone. Now, this gonadotropin releasing hormone released from the hypothalamus, now they act on the pituitary. Here from the pituitary, they give some gonadotropins. Particularly more important is the luteinizing hormone as well as the follicular stimulating hormone. This luteinizing hormone now acts on the Leydig cells in the testicles, and these Leydig cells in the testicles, they produce the testosterone. And now we all know this testosterone has a positive effect on the spermatogenesis. And of course, when the level of the testosterone in the blood becomes a threshold level, then now again it causes a negative feedback on the pituitary as well as the hypothalamus. Now coming to the FSH, that is what we know is a follicular stimulating hormone. This FSH now, which is being secreted from the pituitary, acts on the Sertoli cells of the testicles. These Sertoli cells again have a positive effect on spermatogenesis. Now, but along with this spermatogenesis positive effect on the spermatogenesis, these Sertoli cells also releases inhibin. And of course, this inhibin, when it reaches a threshold level in the blood, is again it has got a negative feedback on the pituitary itself. So this is how the hypothalamus and then the pituitary and then the testicles regulate the spermatogenesis. Now, as I told you, coming to the causes of infertility, I have told you a little bit about this earlier. Now, if we categorize an infertile man in many categories, okay, but almost in around 30 to 35% of the cases, we cannot find out the cause of idiopathic infertility. So we label that broad group is a cause of idiopathic type of male infertility. Now coming to the certain detectable causes, for example, if the male has got varicocele, if the male has got some sort of infection, so varicocele, if it is there, it is to be repaired. If there is infection, that has to be treated. And some pituitary hypothalamus problem, if there is hypogonadism, of course, this has got a treatment, but those success rate is not that good. And if it is a cryptorchidism, then that has to be managed. If it is a malformation, that has to be taken differently. Now coming to this tumor obstruction of these things. So these things, if it is known causes being found in evaluation of an infertile male partner, then it is okay. You can manage somehow. But the broader group remains in cases of idiopathic group, where a lot of after evaluation, we particularly don't find any definite cause of infertility in the male partner. Now, coming to the management, as I have told you already, if it is a surgical things to be done, if surgically can be managed, if the diagnosis comes out to be something that is surgical problem actually, then we can manage this. And for example, if it is a varicocele, if there is some sort of blockage, then can be repaired, okay. Now coming to the bigger part, the medical. For example, if you find there is some sort of hormonal imbalances, okay, or maybe in the form of erectile dysfunction, okay, then there is a role of hormones, there is a role of corticosteroids, FSH, androgen, and whatnot. And of course, in these cases, there comes a role of antioxidant. We'll be going in that in detail. Now, coming to this role of antioxidants in infertility is an updated review. The current evidence suggests that the oxidative stress and in male infertility, sperm motility, sperm DNA damage, all are related. Okay. Now, this oxidative stress is really, it has got a detrimental effect on the fertility as well as the pregnancy. And if the pregnancy takes place, then also it affects the genetic status of the newborn. Now, this is seen then, it is been observed that there is a oxidative stress and it has got a negative effect in the testicular microenvironment, and that ends up in causing infertility, maybe in different way, maybe in the form of having a negative effect on the spermatogenesis, maybe in the form of DNA sperm damage, and maybe in the form of reducing the motility, and finally maybe in the form of changing the morphology. Now, this ROS, the idiopathic male infertility is caused by increased the production of this oxygen species, reactive oxygen species, which causes the depletion of the sperm antioxidants. Now what happens? It is seen that these antioxidants, which I will tell you later on later of my slides, actually, this antioxidant has got a scavenging action on these ROS reactive species, that is reactive oxygen species. And so if the ROS level increases and if there is decrease in the level of antioxidant below a threshold level, and then there causes some sort of damages in the sperm, maybe in the form of motility, maybe in different forms, as I told you already. Now, physiologically, the spermatozoa, it is seen that they have got a low antioxidant carrying capacity. And for this reason, they are very much vulnerable to be damaged by the ROS. Now, to help the sperm to function, particularly in the cause of in causes where idiopathic infertility we have labeled, so supplementation with antioxidants in different forms. In the form, then there is that leads to the development of sperm, and that leads to the development of structural integrity, that leads to the development of DNA arrangements and all these things. Okay, so these molecules are free, these ROS are free radical, these antioxidants are free radical scavengers, and these antioxidants, they protect the spermatozoa by counteracting the lipid peroxidation of the membrane, then protein corruption, and then finally they also inhibit the DNA fragmentation. Now, this is a systemic review that has been studied. It's an original article. Here, actually, different type of antioxidants and its doses, and in relation to the male infertility. So, in these cases, the results came out to be like that. In all around 26 studies were reported that showed there is a significant positive effect of antioxidant therapy on basic semen parameters and advanced sperm function outcomes. Also, there is a good positive outcome in assisted reproductive therapy, and finally the live birth. I mean, now, what are the anti-active ingredients? Now, antioxidants mechanism of action as well as rationale for use. A large number of compounds has come to the market, okay, and it is being, they are claiming that they has got antioxidant properties. But today I'll be picking up some of the important molecules only. So an understanding of the antioxidant mechanism of action of a commonly used that are available in the market and that are also more important physiologically. So before embarking on the evidence associated, and there is very much in clinical practice. Now coming to this one, levocarnitine. No, there is the involvement of the sperm metabolism fully, and it gives the energy to the sperm. The main function of the levocarnitine is in the epididymis, and that increases the energetic substrate for the spermatozoa. It may be involved in the successful maturation of the sperm. Now, levocarnitine is necessary for the transport of fatty acids into the mitochondria, and if the fatty acids are being hampered in transferring, then there is decreased production of energy in the mitochondria, and since there is decreased production of energy in mitochondria, that may affect the motility. So, low level of levocarnitine and that's reduces the fatty acid concentration into the mitochondria, and that finally leads to the decreased sperm motility. This levocarnitine is a water-soluble antioxidant involved in the sperm metabolism that gives the energy and then finally leads to the improvement of the motility of the sperm. Now, in vitro studies of the sperm that is cultured in a media and that containing levocarnitine, it is in that it has got a higher motility in relation to the controls or in relation to the placebo. So these levocarnitine exhibit antioxidant activities through the scavenging of peroxide ions and hydrogen peroxide radicals, thereby inhibiting the lipid peroxidation in the membrane. So that's the significantly lower carnitine levels were also observed in semen samples of an infertile man in comparison to an infertile man, and that finally leads to the oligosteroteratospermia in infertile male. Now coming to this coenzyme Q, it is another important antioxidant. It is really omnipresent. It is present in all type of body tissues, and it is particularly present in high concentration in the sperm mitochondria that is involved in the cellular respiration and plays an integral role in energy production. This contribution rationalizes it in its uses in promoting the as well as the antioxidant molecule. Furthermore, it inhibits the superoxide dismorph formation. So the superoxide dismorph or superoxide, these are all radicals, and that has got a detrimental effect on the sperms. Now, it is seen that a significant negative correlation exists between the coenzyme Q level as well as hydrogen peroxide. And there also exists a linear correlation between coenzyme Q levels in the seminal plasma as well as the motility. So there, if the coenzyme Q level increases in the plasma, the motility is going to increase. Now comes another important, that is selenium. It is an essential trace element which involves the spermatogenesis. It's thought to stunt the form its ability to protect the sperm of DNA from the DNA damage against by Ross damage actually. So selenium is a major constituent of the specific group of the proteins. So there are around 25 selenoproteins are there, okay, and all has got any antioxidant properties. Now, some of these selenoproteins are, like, for example, like phospholipids, hydrogen peroxide, glutathione peroxidases, sperm capsular selenoprotein glutathione peroxidases. So these are actually enzymes. This has got an enzymatic activities. So these help in maintain the sperm structural integrity. Now, selenium deficiency, it has been seen that almost commonly associated with morphological sperm in the mid-piece defect abnormalities of the sperm. So what I mean to say here is this, it has been observed that if there is selenium deficiency to a significant level in an infertile male, then there is a observation of high incidence of mid-piece defect, okay, in the sperm, as well as the sperm motility also get affected. Now, this is another element, zinc. Zinc is another very essential trace element, and it has got plays in a very vital role in the metabolism of RNA as well as the DNA. Is across signal translation action. This zinc concentration of the seminal plasma are found to be significantly higher in fertile men in comparison to subfertile or infertile men. Now, so it is seen that when there is a zinc deficiency, that there is also some sorts of flagellar abnormalities in the sperm. Abnormality may be in the form of hypertrophy, abnormality may be in the form of hyperplasia. So these sorts of defects take place when there is a significant decrease in the zinc level. Now coming to one important red pigments. This lycopene is a bright red pigment and it is a phytochemical, and it is mostly found in the red fruits. Well, like for example, the watermelon, guava, and all these things. Okay, and that it belongs to a class of carotenoids actually, which are sometimes they become of color like yellow, orange, or even red pigments. And most of the time they are there. Almost in all the cases, I mean, all of them are being synthesized by the plants. This lycopene is a naturally synthesized carotenoid, okay, and it has got powerful Ross quenching or scavenging activities. So it makes a major contribution to the human fertility system. And lycopene is detected at a high concentration in human testicles and even in the seminal plasma, in comparison to subfertile or infertile men. Now, this is not hypothetical, still it is under evaluation. It is seen that if in a media, the sperms are being given extracellular ATP, then it increases their motility, it increases their fertilizing capacity, fertilizing potentiality. So in this, but this is still an observation, and further studies probably is required in a large number of couples before to arise in a good confirmed confirmation. I mean, to make it the result a good and to effective, so that more publication also required, more research also required in that. So this is just a hypothetical. It is seen that if extracellular ATPs are given in a hypomotile or even in an unfertile sperm, I mean a hypomotile sperm in a cultural media, then the motility increases. Now coming to another important element, this arginine. This arginine actually mainly affects in increase in the number as well as increase in the motility. So number is also more pronounced in relation to arginine. Now there is a lot of observation in, for example, in couples who have severe oligospermia, oligostenospermia. So when they are being given arginine and they are being given arginine in one group and another placebo group without arginine, then it is seen that there is significant increase in the oligospermia level, I mean the count level as well as the motility level when they are being subject to this arginine. This is in fact an amino acid only. The same. So number of the spermatogen before and after arginine therapy, the graph shows like that, as I have told you. Now some of the fact files actually. It is seen that when a freshly ejaculated sperm is given, sometimes it is really incapable or even it is poorly capable of fertilizing an oocyte. So this fertilization process or aptness of the fertilized sperm depends certain factors. Now this appropriate time dependent acquisition, there is three processes required. Okay, those processes are like, for example, capacitation and hypermotility, then chemotaxis, exosomal reaction. Now coming to this capacitation. This capacitation exactly take place in the uterine cavity, and this is a process of the development, further development of in the form of further maturation of the sperm, I mean to say. So this sperm head is really surrounded by glycoproteins. So what happens in capacitation, these glycoproteins are removed actually, and this makes the sperm more active and more hypermotile. So this capacitation reduces the binding capacity of the sperm even in the rest of the female reproductive tract. Now, after capacitation, now comes the movement. It has to move. The sperm has to move towards the oocyte. So this movement is called chemotaxis. Now, this happens possible. That is because of the some of the chemoattractants that have been secreted by the oocyte. So this oocyte, they secrete some of the chemoattractants, and that attracts the capacitated sperm. Now comes after capacitation. Now, for example, one thing I forgot actually here, this capacitation, if not capacitation, after capacitation in the chemotaxis as well as the acrosomal reaction, I'll tell you later on, okay? There, the calcium is very important. This calcium ion oscillation, this movement is very much important. So here comes the roles of calcium supplementation also. Now comes to the acrosomal reaction. After this one, capacitation, after chemotaxis, now comes this sperm has to perforate through the cumulus sufferus, corona radiata, and then it has to get attached to the gena pellucida. This can be seen here. So what happens? So once this after chemotaxis, once these spermatozoa get attached to the zona pellucida, then it creates a membrane potential there, and that further inhibits the further attachment of any other spermatozoa in this particular oocyte. So after transit through the corona radiata completed, the sperm binds to the zona pellucida at zone 3 level. So after binding, what happens? The sperm and ovum plasma membrane get fused, and the spiling of the genetic material from the sperm goes into the oocyte, and this is what called the fertilization. Now, these three biological processes that I have already discussed here, this fertilization aptness of the sperm depends on the appropriate as well as time-dependent acquisition of the chemotaxis, then first capacitation, then chemotaxis, then chromosomal reaction. All are dependent on the calcium. So here comes the role of calcium supplementation. Almost there is a calcium recovered in almost in every of the three steps. So here, this is what I have picturized here. The spermatogenesis, capacitation, chemotaxis, chromosomal reaction, calcium ion oscillation, and now comes this here in calcium ion oscillation requires Myoinositol. Now, it is an observed, it is in the European Review of the Medical and Pharmaceutical Sciences. It is the effects of myoinositol on the sperm mitochondria. They have observed in vitro. So the concentration of the myoinositol in the seminiferous tubules is found in higher than the level found in the seminal plasma. Now, this myoinositol is also directly increases the mitochondrial membrane potential, MMP, and it is an important apoptotic marker in the sperm cells. This myoinositol seems to have a beneficial effect on the fertilization capacity as well as even on the embryo quality. That is being demonstrated by in vitro studies. So this is what actually, this is an observation. That is in vitro semen supplementation with the myoinositol, and that leads to the decrease in the DNA fragmentation in a cross-sectional study that was being published present in 2015 Asher, and that was published by Parmagini and al. So where they have seen that when this in vitro fertilization, if they are being supplemented, sperms are being supplemented with the myoinositol, then the DNA fragmentation decreases. So this is what myoinositol improves the sperm parameters and sperm reproductive hormones in patients with idiopathic infertility. That has been published in the andrology lab in America. What happens? Published in American journal probably, but this was probably observed in Italy. Yes, so this was a double-blind randomized placebo control trial, and it was probably done in Italy, where around 194 participants were there, and some group of around 98 were given myoinositol, and another group were given placebo of 96 members. Okay, this myoinositol was given 4 grams a day, and for around 3 months it was given. And now what they have observed, that is what was published in American Society of Andrology Lab in February 2015. So what they have found is that myoinositol significantly increases the percentage of acrosomal reactor spermatozoa. That is an important factor in fertilization. And also it increases the total count of the spermatozoa. Also, it was increased the sperm concentration. That is what the total count. And it had got, this myoinositol has got a rebalance action on the LH hormone as well as follicular stimulating hormone, and also it has also an inhibiting effect on the inhibition in serum beta inhibin level. With this, I conclude. Thank you so much. Hello.
Thank you very much, sir, for a wonderful presentation. We are very glad to have you for today's webinar, sir. And it's our honor and learning to hear you, sir. Sir, if you allow me, then we'll take the questions.
Yes, yes, no problem.
Yeah, sure, sir. Sir, we have a first question, sir.
Sir.
That is, whether myoinositol have any role in hormonal parameters in male?
Actually, myoinositol has got a these are amino acid. This has got a positive effect on the hormones actually, because actually basically what is this inositol myoinositol are some sorts of amino acids actually, some sorts of protein. So this has got a positive effect on myoinositol because see all these idiopathics cause of infertility. If there are some sorts of nutrition deficiency in infertility, those couples are lacking sufficient amount of nutrients in their sense. So nutrients means antioxidants. So what I mean to say, sufficient nutrients are given. The nutrients means myoinositol. Then this has got a positive effect on the this FSH as well as LH. Hello.
Yes, sir. Thank you, sir. So we have one more question. How important is morphology in semen analysis?
The morphological, what I feel that actually morphology should be at least it is very important. But thing is that the motility is more important than morphology equally. But more normomorphal semen with a good motility, progressive motility is the parameter. See, around 4 to 5% of the sperms with normal morphology, the parameter is like that. But if they had got a progressive motility, then it's okay. You can go for XC or I mean a part of a artificial reproductive technique. So what I feel is the progressive motility along with the morphology is equally important. And morphology is not that a good amount of the sperm should have a good normal morphology is not that. Only around 4 to 5% of the sperms have got a good morphology, but important they should have a progressive mortality. Then we can subject to her an artificial reproductive techniques.
Thank you very much, sir. Sir, no more questions from the delegates. So if you allow me, then we'll close this webinar.
Okay.
Thank you very much, sir, for your valuable time and sharing your experience and thoughts on male infertility. We are very glad to have you, sir, and we look forward for your continuous support for upcoming educational activities as well. Thank you very much, sir. Many thanks for the
good night. Good night.
And also thank all the delegates for participating in this webinar.
Thank you, everybody. Good